We will not pursue the type of government-run health exchanges being forced on us by Washington. Despite the rose-colored rhetoric coming out of D.C., these exchanges are nothing more than a way to make the state do the federal government's bidding in spending massive amounts of taxpayer dollars on insurance subsidies that we can't afford.
I'm joined by Ezra Klein of the Washington Post and Avik Roy at the Manhattan Institute. We're talking about Obamacare gone right. And unlike South Carolina and the state of California, they are building the exchanges. This is the beginning of the actual implementation of the core part of this bill, the part that's going to be the trickiest and also the part that was kind of the heart of the bill when it was explained to people. It's getting these exchanges a regulated marketplace for folks to buy insurance. And there was announcements about what the price tag of those insurance packages would be. And Avik, you wrote a piece that got everywhere, went viral in conservative media, saying, oh man, it's a ripoff. There's a huge rate shock. You're going to be paying for more insurance if you are entering into this individual marketplace.
Yeah, so what happened was that the California Exchange issued its presentation of what the rates, what the insurers said that they were going to charge in different rating regions, so basically collections of counties across the state. And what I found when I looked at those numbers and compared them to individual market plans sold on e-health insurance is that it's about double, give or take. It depends on the county, it depends on the area, depends on your age, depends on a number of other factors. But if you leave subsidies aside, right, for the typical person, particularly for typical young people, they're going to have significant.
You're a young person. You're not getting insurance from your employer. You're going to go out into the individual market that you're now mandated to do. Right. You're going to buy this program and you're going to pay. You know, maybe before on ehealthinsurance.com you can get it for $150. It's going to be $300 now.
Right.
That was your finding. Ezra, you wrote a response about why this was not the sticker shock that Avik had argued, and why is it not the sticker shock?
So I think we need to be clear about what the individual market is. So I did the same thing Avik did. I went to ehealthinsurance.com. I come from California, so I looked at Irvine, California, my hometown. And the issue is you can go and get the cheapest plan. That's about $109 for a 40-year-old non-smoking male, which is the measure he used. And the thing is that $109, which is the measure he used to say you get a double price, you get a doubling in price, that is a teaser rate. So you click $109 and then they say, well, have you ever had a headache? Is there any history of cancer in your family? Is there heart disease? Have you ever hurt your leg? Do you have an ulcer? And as these things mount up, the price changes. So about 12% or 14% of the people get turned away entirely. Another 12% get a higher price than that $109. And so about a full quarter of the people who are signing up for this bill aren't getting it. And so to use as your baseline for the comparison here, a baseline that looks only at the price paid by young, healthy, relatively affluent people for the absolute crappiest insurance that can possibly be offered in the insurance exchange, and to leave aside what is happening to older people, to sicker people, to women who won't be gender rated against, and to everybody getting subsidies, you've set up a comparison that is just utterly ridiculous.
Let me, before I let you respond to that, I just want to interpose some personal experience, which is that when I was a young freelance writer and trying to fend my way on $8,000 a year, which is what I made my first year of freelance writing, I purchased the cheapest catastrophic care on the individual market. Good luck trying to get them to respond to you when you actually had a medical bill. I mean, it was an absolute disaster dealing with them, right? Like, I was paying my premium every month. I went to the hospital. I tried to get them to reimburse me. Like, forget about it, right? So there's also this thing that this is a very unregulated marketplace.
There's a vigorous debate, which we don't have time to go into, about what kind of plans you can shop for that $109 price. And you can read our blog post to get a detailed explanation of that. But to the point about the percentage of people who might get charged a higher rate. Now, the point I made in response to Ezra was that means 3/4 of the people are actually getting that $199 rate. It's not a teaser for them. And so those are the people who are actually going to pay a lot more money in the system. Now, maybe we think that's a good thing. It's a good thing for those people to pay double for their health insurance because we're now protecting the sick, et cetera. But that's a debate we didn't have really in 2000.
Well, but there's also the subsidy issue, right? That's the sticker. Ezra, please respond.
But this is a debate we had. I mean, this is what actually frustrates me here. So, Evan, I remember doing this debate over and over and over again. So Evan Bayh wrote this Congressional Budget Office. He was a senator back then. He said, what's going to happen to average premiums? The CBO came back and they said, well, average premiums are going to go up a bunch. And then people like me went in and looked at what they said, and they said, well, look, average premiums are going to go up, but that's because people are going to start having to buy better health care because they're going to get subsidies that are going to make them pay for better health care because now they can afford it, because we're going to do all this aid, because we're not going to allow for the age rating, because we're not going to allow for the discrimination. This was out there, and we talked about it a lot. I mean, at its core, health insurance, what we're doing here is we are redistributing from the healthy to the sick and from the young to the old, and we are putting in big subsidies to help people who are poor. That is what healthcare is, and it has always been that way.
We are pooling risk, and when you pool risk, there are going to be some winners and losers, and I think pooling risk is part of what makes the social contract beautiful. Avik Roy, Senior Fellow at the Manhattan Institute, and Ezra Klein, MSNBC policy analyst. Thank you, gentlemen, both.